Gentlemen, I've always been wanting to say this for a long time, being the moderator and the host of the technology part. Welcome to Fantasy Island, because that's what we're talking about here. Technology is now and beyond. So when you talk about technology and how it works and will work within the aspects of gathering data, of creating medical mobile units, of creating programs that's going to change the world, this is where it starts. And this is an area where folks enjoy. If you're a big sci-fi fan, this is where it happens here, because this is where the fun begins, as far as when we started to talk about medical surveillance, when we started to talk about gathering data, when we started to talk about electronic medical records and what that can do in the hands of the patient and the doctor. This is where it begins. I'm going to, the bios are in the program, and the pictures of the folks here are in the program. I'm not going to delay this any longer. I'm going to go straight. We're going into Remy, Dr. Ferguson, and Dr. Carter. We'll start off with Remy Sakira.
Welcome. I am Remy Shakir. I'm with Aegis Health, and from a technology perspective, we've been looking at cancer both from prevention and control, so not just the actual response. And a big part of that is understanding what the baseline is of the community, the population, and ultimately, if you look at precision medicine, coming down to the individual. And a lot of that is based on having data and being able to understand what some of the social determinants of health are that are contributing to one individual versus another individual having a cancer or having a secondary cancer, where you can cure the first cancer, but why does that individual get the secondary cancer? And so looking at big data as a buzzword, there's a plethora of data that is out there, but it's how you break down the silos and bring that data together in a way that you can actually look at the patterns and be able to understand both environmental factors, nutrition factors, education including health literacy around prevention and control of cancers, and then how you can engage both the patient and the population, the community, so that there are early screenings, early detection, being able to better engage with both the provider and the care plans as well as the whole care team. And when we look at the surveillance, if you will, it's how do you get all of these different stakeholders to bring the data together in ways that create a cohesive whole health view of the individual and of the community. So we have the public health department with certain registries. We have vital records that might sit there. You have claims that might sit with healthcare finance. You have the private payers, self-insured payers. But once you start to bring that data together and do it beyond just a research study, you can really baseline not just patterns and trends at an aggregate level, but understand what are some of the drivers or contributors for either from an ethnic perspective, even like from a zip genetics perspective, where we can understand how to better target interventions and outreach programs, and then also being able to look at within specific individuals who, let's say for breast cancer, are you actually then considering I should also have my sister or my mother or other family members being screened. So being able to flag who is at a higher risk and be able to better target resources versus just a shotgun blanket approach to here are outreach programs, here are ways that we can, educate for, again, early detection and screening or prevention programs. So a big part of what we've been looking at are who are the necessary stakeholders that need to come together? What is the data that each one of these silos has, and how can you bring that data together securely and being able to gain insights from that, and then provide that back to stakeholders so that, one, you have better targeting of your prevention and your screening and your outreach programs, but then also you have knowledge transfer and sharing, because researchers like to do research, but you need the researchers and the clinical to be able to come together and be able to gather those insights from what we're actually observing, from individuals and from the community, as well as be able to match that up also with new payment models. If you look at the data, this is what somebody might need, but can they afford that? Are payment models from the insurance companies set up to best match high-risk individuals with the best plan and the best coverage so that you can ensure that people are getting the best treatment? So there's a combination between bringing data together, gathering insights, what are the best targeted programs for prevention and control as well as for intervention, and then how you bring that back together for policy, and policy tying that back for, again, how are people able to finance their own care, but how does the system also not go bankrupt, where you can have, from a self-insured employer or a public payer, if it's $250,000 per year for a cancer patient, our system isn't financially set up for that. So I think that there's a great opportunity for getting the right stakeholders together in the room from a collaborative perspective, but the other is looking at what are ways that we can, with technology, be able to break down the silos, make the system more efficient, be able to better target where we're putting those resources, be able to facilitate the knowledge transfer, if you will, and then understand what are the interventions that are most effective and what are we going to finance from that perspective. And then the other, from looking at technology, not just in terms of bringing data together, but there's such a great opportunity looking at teleconsults. There's the ECHO program, which was developed out of University of New Mexico, which from a cancer perspective is where different institutions can collaborate from knowledge transfer and sharing. So how do we build capacity, leveraging technology so that we're not trying to build the exact same infrastructure capacity in every single center, where you can have a center of excellence, which then has a network of other institutional partners that they can collaborate with. And that's where you can build that capacity in a financially sustainable way, and at the same time better understand where we need to target, and also what we're learning from different populations, so that we can have, from a precision medicine initiative, more effective interventions. So that's a big part of what we work on in terms of bringing the parties together, how to look at the data, and then how to finance the system and new targeted therapies that are coming to market. So I don't know if there are any questions on that, but
We'll hold off on questions until the The next speaker is Dr. Fred Ferguson.
Put this in so I can hang around. Okay, great. Yep, that's it. Is there a port for this? Yes. Great.
Would you like to actually access these later on?
No, I'll get it right now. Is this on?
No, it's on. You want me to mute this?
Yeah. Okay. Slide's not up though.
Okay, good afternoon. I'm Fred Ferguson. I'm a pediatric dentist, so before you go like, well, what's this about? This is a very squished down version of a message that I want to give to you that will reinforce what Remy talked about. In fact, pretty much everything you've heard today. This is the message I want to give to you. I'm an educator. I've been educating medical students, nursing students, dental students, patients all my life. I look at you as a parent. We're talking about a lot of things about health, and really the bottom line is I'm asking you, like I say to a parent of a 3-year-old whose mouth looks like that picture out there in the lobby, the bottom line is, can I get you to change the way you love your child? Okay? Okay. So we've talked about this a little bit today, this interplay of genetics and non-genetics. This is what we all have going on. It's a complex relationship. But when it comes to your health management, that is what you do, all of us, it's really about the non-genetics. You know, our genetics is impacted as soon as we're conceived, even in fact before, but mostly after. So I'm saying to you what we need, we're in this evolution of healthcare. It's all logical. I'm saying we need a revolution. We need a paradigm shift to recognize, and I'm talking to each one of you in the audience. Oh yeah, by the way, after your meal today, what's the most important thing that you could have done? You can't do that here. You don't have a toothbrush. So what's next? Thank you. Take the water. Swish it around. There you go. Okay. All right, so we've all talked about this today, this social determinants thing. What I'm saying to you, the message is that I, as your doctor, your payer, or public health policy, whatever you want, I can't do better than you can do for yourself. The problem in our healthcare is that we should still treat the patient like a patient and not expect the patient to act like a partner. So we can do all the fancy healthcare, back-ended sick care we want, but until we put the patient in a position to be a partner, it ain't going to work. And the two groups down in DC who were arguing about a month ago, I'm laughing at them. Neither one of them has a clue. So this is where we have to get to, and we are talking about the most prevalent chronic disease in the world, tooth decay and bone loss around your teeth. In fact, I could do a health survey of everyone in this room, and the most prevalent health problem you have in this room is bone loss around your teeth, and if you don't know it, you're in trouble. Just a month ago, a paper came out saying they did a study on women over 50 years of age, and they found high association between women's life expectancy and the number of teeth in their mouth left. Just like the guy, just take a look at that guy out there, okay? Okay. So, Ray says, Fred, you gotta keep it down, you gotta keep it short. So, I'm here saying to you that I've been developing this for about 20 years. I've been on this path for about 30 years, and it was as a result of a parent who had 3 daughters, all had born with holes in their hearts, who came to me with busted mouths because of predictable medical and dental care, came to me with this destroyed dentition called early childhood caries. And when it dawned on me that I wasn't getting through, I said, I'm not going to say her name, what's going on? And she looked at me and said, I know you can fix their teeth. And that's when I realized I just wasn't getting through. She was holding me accountable, and I had to make her accountable, so I had to change my language. Some of it you'll hear and see at the end. So I've been developing this process that will do 3 things. It will bring accountability in consumers. It will allow consumers and providers to better collaborate, be partners, and it will provide health measures, forward-looking anticipatory data to healthcare instead of this stuff we got now, in which we wait until the fire to start, and then we run in to see what we can do. Okay? Because they both have to go together. So, what's my SMILE guide? I'm going to read it. And it's secure, interactive, and personalized oral health education and guidance tool that empowers consumers to become competent oral health managers. This is a library of questions presenting, I didn't make this stuff up, presenting well-recognized risk concerns to oral health. Many of these risk concerns are well-recognized, Institute of Medicine, as threats to long-term health and quality of life. And as Dr. Ware just said this morning, you should know your mouth. You know, when you go to somebody, healthcare, you should know about what's going on. You shouldn't be depending on me to tell you what's going on because it's what you're doing. It's not about my healthcare. And if you don't change your behavior, our partnership will fail. How does it work? You create a health folder specific to you by your gender and age after puberty. Age after puberty. It's personalized from this bucket of questions. It selects out, the software selects out questions that are specific to you. You answer the questions yourself. You don't need for me to tell you. Okay? All the information is saved. You get to it 24/7. And you can enroll anybody in your home, from your 1-year-old child to your 80-year-old dad with Alzheimer's, who you have to care for constantly. Doesn't matter. Doesn't matter. What happens is that you self-identify your health journey. The message is that if I can pick one thing about you, okay, 3 things. I would need to know your age. I'd need to know your gender past puberty. And I just need to look at your mouth. That guy out there. That guy out there, his mouth tells me where he's been, where he's at, and where he's going. There's not a thing I can do about it. We have to get to the point where the consumer is truly the center of our efforts. So the user receives oral health intervention specific to their or their family member's situation and stresses the needs for timely dental visits. Oh yeah. When's the last time you guys, excuse me, I'll be done very quickly. When's the last time you guys been to a physician, OB, primary care, diabetes doctor recently? They ask you about your mouth? Not your OB. Not your diabetes doctor. Not your primary, ain't happening. Good. You need to stick with them. Okay? Certain responses direct the need. Like somebody said, when it hurts, that's too late, homie. It's too late. I contend there are 2 things we could do in healthcare that would completely transform our system. You know how to take your mouth, and you know, because you constantly do this, and you go to your dentist to confirm your behavior. That's what this does. So, here's what happens in the system so you know what's going on. I'm going to connect this to this. I look at that guy out there. Oh yeah, he's burning up. He's burning up. And if they don't take care of his mouth, I don't care what they do to the rest of his body, he's going down. This is my last slide. Why I've been successful in healthcare? Because I've gone what I call tribal. I've gotten away from the medical terminology, all this stuff, it just doesn't work. This is my mantra. This is my whole talk. Think about it. What this means is that when something happens to your tooth, either in development or something post, trauma, caries, whatever, acid erosion, reflux, your tooth shows it to me for the rest of its life. And you can't lie to me about how you're taking care of your mouth, because your gums will tell me the truth. This is what makes oral health such a great portal to do all the things that Remy's talking about. Because in this, we can take in information, and now we have data that connects the 4 major stakeholders. The problem now, each one of them has their own data set, and they don't know what each other's talking about. This will unite everything and transform healthcare to improve value. That's what CMS is talking about now. Value, not just outcomes, and cost. But the problem is, you got to do your push-ups. You can't act like, hey, I'm just going to do my thing, and then when I get sick, then I step through the glass window. It ain't happening like that. Thank you.
Okay, the next presenter from the space station, Prince George's County, and Dr. Ernest Carter.
Thank you. Good afternoon. Can you see that? All right. I'm just going to talk briefly about a subject that Mr. Bridgewater insisted I talk about. I'm going to talk about telehealth, medical mobile units, and how it has an impact on rural communities. And this is going to be very brief because, as you could imagine, there's a lot there, and you could talk about this for 45 minutes and not cover the subject well. So what I'm going to try to do is sort of give you the very high-level look so you can understand how telemedicine could have an impact in a rural community. Now, I will give you a little bit about my background. I started doing telemedicine in the mid-'90s. Actually did meet Mr. Bridgewater trying to do telemedicine I think over in Petworth community, if you remember. But I also have done telemedicine in Nigeria, South Africa. We've done telemedicine in Benin, and a few other African countries. And I started out looking at telemedicine in Africa and Kenya back and that was all of it. And just to tell you that it's tremendously difficult to do this. But I think that as the technology evolves, and I think if you start understanding some of the principles, it actually can be a way to help relieve some of the overwhelming need there is not only in Africa, but anywhere that there is a significant amount of need and very few resources. So I'm just going to start this out by just describing in any kind of rural setting, but there's always a really reduced population, no matter how and they're separated by distance. They're usually, in this country, most of the people don't have a lot of money. They're either uninsured or underinsured in rural communities. And when you go into a rural setting and you go into a medical facility, you'll find out you'll have brand new equipment that has never been used, or you have equipment that has been used but nobody knows how to take care of. And that's a huge problem. You have, and then you don't have a lot of specialty services. You have people, specialists and particularly specialists, and not a lot of primary care people actually go out into the rural to do anything. They don't like to go there. They like to go into the city or into an urban environment. So the workforce is really, really reduced, and that can cause quality problems in healthcare as well as staffing. And I don't need to tell you this. You know this intuitively. But one of the other things is that the patients themselves don't like to travel to get to the doctor. So you got these tremendous needs. You got people who have low health literacy in many cases. You have drug problems going, and depression, behavioral health problems going, and there's a huge lack of just coordinating people's care. So the rural communities have huge needs, but you know what? And when you look at an urban environment, you find the same parallels. It's just that because all of it comes out of poverty, all of it comes. If you're rich in a rural community, you do pretty well. You can get there. You can get your health care. So what we're talking about are people who don't have the means, and when you don't have the means, it really becomes difficult. So just to tell you a little bit about what telehealth and telemedicine is, because those terms are used all the time, so I want to be sure you know what it means. They use them interchangeably. If I were to define it, I would say look at telehealth first, because telehealth is basically a way to improve health outcomes using telecommunications. That's all it is. And so when we started saying telemedicine way back, you're talking about actually practicing medicine over a network, a telecommunications network. And then people started doing other things like health promotion, health literacy, all these other things, and more public healthy things. Then it became telehealth. And then when people started getting mobile phones and the technology got better, it became M-health. But all of it is exactly the same. If you can improve a health outcome, then you're practicing telehealth. And if you're doing it by practicing clinical medicine, you're doing telemedicine. So that makes sense? I hope it does. So these are some of the uses of telemedicine. You can do a remote consultation where you're the doctor and there's a patient over somewhere at a distance, and you connect them up with a telecommunication connection, and if you can do live video conferencing with them now, it used to be it was very difficult, but you could do live video conferencing and help them if they have some peripherals on that other end, like a blood pressure cuff or whatever it is they need to capture those clinical biometrics. You can have those, otoscope, all these things that you could capture data so that the doctor or health provider can make a diagnosis on the other side and prescribe treatment. You're doing telemedicine. That's a teleconsultation. Or another type of telemedicine is that if you've got a patient and you need some help, you can get a specialist to come in with you, and you're doing so the specialist is doing a consultation between you and them over distance, and you're using video conferencing. That's live, interactive. You can do it by storing by videotaping everything, gathering up all the information and sending it to a specialist, and they come back with a diagnosis. That's called storing forward. Those are all the ways you use telecommunications to do telemedicine. And that's what telemedicine is. You can do outsourced diagnostics where you have an image here and I send it out somewhere and somebody sends it back and they say this is what it is. That's telemedicine. All of those things are telemedicine. Telehealth is that if I have a health promotion campaign and I want to get that to a certain population, and I want to do it over telecommunications means using multitudes of social media, or whether I use avatars or whatever, that's telehealth. That's what people call telehealth. But all of those things are all things that we have right now that has improved over the years, because it used to be that it was so difficult to do because the technology wasn't there. Now the technology is there and we can do those things. So when you combine that with a mobile unit, you actually have a very powerful way to get access to care into a rural community to meet those needs. Now, I'm going to put an asterisk by that, because that in itself doesn't do it, but it is a way to start to do it. So Verizon actually, I put this up here because Verizon actually created this telehealth mobile van unit. I thought it was pretty good at the time they did it, because I think it's in Southwest Iowa. They took a mobile van, and they put, because they're a network company, they really souped up the bandwidth and put it on a 4G LTE 4G network, and they went. If you've ever seen, I think this is in Red Oak, Iowa. If you've ever seen it, it's just really spread out. People need this care, and it has this van actually has had pretty good. This mobile unit has had pretty good success in doing what it does. But what you can envision is that you can take a mobile unit, if you outfit it with telecommunications, if you put the right diagnostic equipment in it. So if you're doing cancer, you'd have to put that in there. You can do mammography, you can do all the things you need, or if you need to do post-surgical follow-up, or if you need to do tele-oncology, you could do all of that in a mobile van on the networks that we have now with the technology we have. So we can do these things, but what is the real problem? Why doesn't it work? You know why it doesn't work? Because it has to be part of our health system. So if you're doing telemedicine, it has to be linked back to whoever the provider is that's taking care of those patients. And those providers should be in a patient-centered medical home, where they're using this advanced technology to help manage that patient. So there's a continuity of care. But not only should the patient-centered medical home be connected to your mobile van, but so should the whole network. You should be sitting, so these entities, whether you have a mobile van or not, however you're doing telemedicine, you need to be sitting on a health information exchange. And it needs to be, and you need to have applications like care management applications, medication therapy applications, all your disease registries, all of the information needs to be integrated into something that looks like a longitudinal care record, so that those people who have these great needs, those needs can be met. And that longitudinal care record involves not only your medical, which involves about 20% of your need, but it also has to involve your other social determinants, which is about 40% of your need, your behavioral health, which is again about 35 to 40% of your needs. And then if you're doing precision medicine, your genetics and everything else. So you have to look at the whole person. You have to have an information system that captures all of those things. And then you have to have a record that reflects that. So to do telemedicine in its narrow self does not help improve a population. Telemedicine is an add-on, is an adjunct. The mobile van is an add-on, an adjunct to the total system. And the total system involves having a primary care doctor in a patient-centered medical home connected to a whole system where of diagnostics, which includes hospitals, nursing homes, all connected so that we can really take care of a patient based on their needs. So that's what I wanted to be sure I talked to you about. That's my last slide. Thank you very much.
Okay, so the mother spaceship has landed. It's time for questions. Anyone has any questions? Any questions?
I do. The panel, and especially the doctor, and I live in like I said earlier, I live in Virginia, where we did not expand access to health care or expand access, which meant we didn't accept the federal financing for Medicaid in our state. And I see technology could possibly bridging some of that gap. One of the things that I read about every late summer is the folks the doctors that come together and go to Southwest Virginia to provide health care, where the local hospital had to close down because it didn't have the financing, because there isn't Medicaid for the patients, so on and on. How could these systems help supplement or help maybe even bring about better health care for the individuals living in rural areas like that, where there isn't primary care? And then how do we connect them to a primary care provider if they're living in an area? How does technology connect them to a primary care provider when there isn't a network provider for them?
I'd like to answer that. One of the advantages of being a pediatric dentist, okay, when I'm looking at a child, I try to have the parents understand I'm looking at you. Okay? You see where you are, tell me what's bugging you, and so you're my patient, and it's your behavior and your insight. Well, I have the 4 words. Attitude. First you have to get somebody's attitude straight, because we educate people. Doesn't mean a thing. So if I don't get your attitude changed, then all the other stuff I'm going to give you, awareness, maybe behavior change and skills, they go out of the window. So when it comes to your behavior, you don't need a doc to talk about that. I could train a high school kid, okay, how to go around a community, or let's say a group of moms, with young children. I could train them how to go around a community and train the moms usually, or grandma, because mom's out running around working, about how to take care of that baby's mouth. Okay? And by having that visit done over and over, again, I'm saying that this reflects that social determinant things. People are doing things that they don't even have an idea why they're doing them. They don't even know. And then they have a problem, and then everything breaks down. Everything breaks down. So I'm saying, if we look at families, that's what people talk about population health. I say, look at families. Okay? I've had homeless families come to me. I just ask mom some questions. I know mom is on point. I don't have to look at that kid. I can ask all other kinds of questions. Or I can look at mom and say, oh boy, I know where I'm going. Okay? So I think we have to start thinking about, we started with telemedicine, telehealth. I think we have to start thinking about communities owning their data, owning their culture. See, I have a saying about dentists, I'm sorry. My problem with dentistry is we're still thinking like a bunch of dentists, not as lifestyle coaches. I contend that this is really a very simple way of getting people to understand what their power is. I like to say, when I talk to a mom of a 2-year-old, say, who's brushing Johnny's teeth? Because I know the answer, and the answer is, oh, Johnny won't let me brush his teeth. Okay, and I say, Mom, and I ask you a question, okay? Just take a little time. Would you tell me that Johnny wouldn't let you clean his butt? And I just let it sink in, and I get the eyebrow raised, and now I got your attention. So much of what we're talking about starts in families, but I'd like to say behaviorally DNA, and they are transmitted as children become codependent, and then independent, and then we see all these other things going on. So I think we need to understand, in New York State there's an effort to address these problems called DSRIP, Delivery System and Reform Incentive Payment Program. And they're trying to address, they want to reduce hospital admissions, readmissions, and emergency room visits by 25% in 5 years. And I'm telling them, you're looking at your patient, but what you fail to understand that there's a whole vertical list of people who are not your patients yet, that you have to understand what you're dealing with, what makes people get into the trouble they get into, that most of the people in this room don't have. We wouldn't even imagine it. And we can't imagine what's driving the people who do have a problem. Some of us have a better idea than I do. So I think we need to start thinking about really finding ways to help people monitor their health over time and give them tools so they become autonomous instead of depending on us to do health care. And we just have to keep moving that way. We have to give up that pot that we want to own. We have to give it up and have to find ways to do it. And they exist in communities. We have to go in the community and work with them. Because as the funding goes, we go away. Then what?
Anyone else like to respond? Dr. Carter?
Well, I think I'll focus on the, you asked about how technology might, you asked how technology might be utilized to help in light of the fact that there's not a lot of resources going. Well, in one of the things we know about telemedicine is that about 70% of diagnoses can be made using that without touching the patient. And one of the things you also know is that the devices that are out there that are capturing more of the biometrics are improving every year. So you got people running around with Fitbits, and I remember when we were trying to build it, it would be big, you couldn't have a Fitbit. So what happens is that most of the basic biometrics can be captured within your home. Most of using video conference can be in your home. If you design a telehealth system such that you can connect to the doctor, but also connect to social services, also connect to, and then create systems that are coordinating a person's care as opposed to coordinating their medical care, but coordinating all of their care, so you can start to have an online social services, online behavioral health, online. Mm-hmm. If you design those systems so that you know they won't capture all of your populations, but you do the risk stratification so you know who has the greatest need, and you design your systems around that. And for those people, and you make sure your van or your mobile system gets to them. And the people who have moderate needs, you can do maybe just online. If you design a system thinking about the need as opposed to thinking about the money, you actually can come up, I believe, especially with the technologies we have now, with an optimal system that you can optimize around people's needs and how we're going to use our limited resources and use all the sophisticated technology to meet that need. That's what they do when they send a person up to the space station. I mean, they send a person to the space station and they monitor everything and they have minimized their cost. So in the year 2030, and then I'll be through, it's going to be highly robotic. I hope you all know this. I know you all know this. But it'll be highly robotic. It's going to be highly online interactive. And you're not going to need a doctor as much because you're going to have smart homes that can do your diagnostics right there, monitor you right there, know where you're trending, and your DNA is going to be telling you, your precision medicine is going to be telling you what you're trending towards, your diabetes, hypertension. So we need to start being smart about getting those systems to people who have the need, and I do think we can get there. And Virginia is interesting because that's where our regional telehealth center actually is. So they do a lot of thinking, I know, around this. I know I do. But we're not there yet because, you know, everybody, we got too much profit motive in our society. So if you got profit motive, you got people trying to make $1 off the next widget, and we can't be that way.
And that was my follow-up question. And so you develop a system where the screening and the healthcare is provided in the home like that through this, with healthcare being provided through a technology system where a person's in the home. Who picks up the cost of that? Who pays for it?
Well, you know, it's interesting because I think that it's going to go into, the people who pick up the cost are going to be the payers in our system. In our system, it would have to be the payers. And the payers are driven by, say, making sure they can, and if that's the case, then we have to be smart enough to show that there's a value to what this has just done. It saved them money. I hate that. You want to speak to that? I'm going to let you speak. But that's what they want. And so if you can show a value to that this person, if you didn't put all these things in their home, they're going to drive up the cost. They're going to cost you $10,000 a year. You put this $1,200 worth of things in their home, and it's going to cost you $3,000 a year. They're more likely to start trying to understand it. Now, I have to tell you, I've tried that over the last 20 years. But it's actually, people are really talking about it now. 20 years ago, they looked at you like, are you crazy? So there's trends, and I'm optimistic, but I tend to be that way.
Thank you.
Remy, like for you to respond to this saying, money is data and data is money. Pretend that everyone in this room are entrepreneurs and they're going to write a proposal. How would analytics influence a community, the government, and community health workers?
Well, I'll answer that from two perspectives. If you think from a banking perspective, you can go to any bank nowadays with your debit card, and if it's Chase or Bank of America, Wells Fargo, they know who you are. They have the ability to understand whether you have that money in your account, if you will. When I think from a healthcare perspective, how difficult it is to pull that data together, whether you are a community health worker or a provider or a payer, and get a full view of who you are. And in banking, you have a FICO score. I know your credit worthiness. I know your debts. I know your ability to pay. I know a general idea for how you're going to perform in the future based on your past. In health, money is like your FICO score because you have behaviors that you have gotten to you to where you are, and you have behaviors that are going to put you somewhere in the future. So if you have the ability to pull that data together and analyze in a comprehensive way, this is who this individual is, this is how we predict that they're going to perform from a health outcomes in the future. These are the needs that they have. These are the risks that they have. That's where I think government, payers, providers can come together with that data and really understand what is the cost of this individual and how do I best invest in this individual. And I know we've talked about accountability, so how do you get the individual to invest in themselves so that the whole system becomes sustainable? So we don't have a FICO score for health, if you will, today, but I think that's where the market is going to be going in terms of how do I match you with the best provider-payer network? How do I give you the best care plan, if you will? And then the other aspect is, how do I show that return on investment for putting resources into this individual this way versus a different way? And whether you look at it as co-payments, co-insurance, et cetera, you know, how do we have some shared value, and not do it just as a marketing term, but, you know, what's the shared value to the individual, what's the shared value to the system?
Yes.
So I get the benefits of, thank you for that, and I get the benefits of going to sort of a FICO score for your health, but immediately I thought, well, what happens to low-income families or people who may have a lower FICO score? We know what happens in general relative to credit. Or what about people that have pre-existing conditions? How does that health FICO score benefit them?
I think that you can aggregate, I think you're looking at the distributions. And so distributions doesn't necessarily mean your social economic status. It can be that you eat healthy and you exercise and you take care of yourself even though you're at a lower social economic status. Can I invest in maybe health literacy or making sure from transportation and housing and education and other resources that I'm better directing them there so that you're normalized across, you know, the total population. You can have the affluent smoker, you know, lethargic, you know, not eating well, you know, flying around the world and not exercising and having a steak and a little bit, you know, too much to drink. And that person is still an outlier from the distributions, you know, from a FICO score. So it's where you do need that whole view of the individual. So it's not about total credit worthiness, if you will. It's about from like a baseline and a target. How are you performing as an individual and as a system relative to where you're forecasted to be? I don't know if that answers it.
Make one statement about the person asking. You know, it's not as far-fetched to have a FICO score because Medicare does that already. You can't go to a physician and have Medicare, you know, the healthcare system for seniors, and think that they can open it up and see everything about you, even how you're sleeping at night, what diseases you have, no matter what physician you go to. Your Medicare is like
Okay, that concludes this session. Fantasy Island is closed. The airplane is taking off. But before they do, will you give them a warm thank you?